I'm the Director of Operations at Vision Forward Association, and I am one of the co-chairs of our Data and Research Committee as part of the Aging and Vision Loss National Coalition. I'm really pleased today to present our third installment of our data-driven science webinars. The focus of today's presentation is around eye disease and vision loss among nursing home residents aged 65 years or older, the Delaware study. So I'd like to start off by introducing one of our presenters. Dr. John Cruz is one of today's presenters. Many of you may know him because he's been a part of some of our previous webinars. He is also the co-chair of our Data and Research Committee along with myself. John has been in the field of vision loss for decades and is currently a retired member from the CDC, in which he had a role as a research scientist for the CDC. So I'm going to turn things over to John then in order to introduce our other presenter, and that way then we can kick off today's presentation.
Thank you, Jackie. Well, I get to introduce Bill Monaco, and honestly, Bill is one of the most interesting people I know. So I just suggest that sometime you try to spend some time with him. Bill spent many years in the Navy, 20 years in the Navy. He was assigned to the Marine Corps. He's a pilot. He was an advisor to pilots in the Navy and Marine Corps. He was the director of optometry services for the VA. He was the dean of a college of optometry, and he most recently was the director of the PhD program at Salus University, where I met him. And he is a great colleague, remarkably productive. And I don't know really why he has me as a colleague, but he is just a wonderful, engaging, talented man. So with that, I want to Bill's going to begin the first part of this presentation, and then I'm going to jump in. So it's my great pleasure to introduce Dr. William Monaco.
Thank you, John. It is really a pleasure to be here today and to have the opportunity to share with you some of the journey that I've been on and have shared with John recently, but I've been doing vision research in aging communities for more than 20 years now, kind of behind the scenes as a clinician. So I'd like to start that off and show you some of the things that we've done and hopefully make some suggestions that will result in some benefit to this very important community. So let's go, Jackie, with the next slide. So just to give you a little bit of a background in terms of how I ended up doing eye care and skilled care facilities, it actually started around the year 2000. I was exploring the need for nursing home eye care. I just completed my term as the Director of Optometry Service for the Department of Veterans Affairs. And so I just started contacting facilities in the local area. And within 7 months, I had 23 facilities. It was an amazing process. And so I found that the more I asked the question, the less there were good, valid answers for why that service wasn't being provided. I did relocate to Delaware, and I was surprised and maybe not shocked to find that when I relocated there, it was the same scenario. Within less than a year, I had 25 nursing homes that I was covering. So in this presentation, I'd like to discuss how I've approached the problem over the years and how much I've learned from actually being in the trenches and providing the care. And so I'll talk about the problem and hopefully the impact, the good impact of good comprehensive eye care. And then we're going to propose maybe some solutions for this. So we can go on to the next slide, Jackie. Just as a little bit of background, and I'm sure that many of you know this, but we were shocked when we really ground out some data back to the beginning of time, actually the birth of Christ. There were about 300 million people in the United States, or in the world, in that time. By the 19th century, that number had risen to 1 billion. And in the first decade of our 21st century, it increased to 7 billion. And now we're anticipating that it will reach 8 billion. So the population has increased by approximately 1 billion people in 20 years. This we know is having and will have a significant impact on the delivery of care, on the strategy of the delivery of care in the populations that we're serving. So that's what we're going to evolve into with the next slide. So how will it affect how does this distribution affect it, or what we call the graying tsunami? Because this process is going on worldwide and it has worldwide implications. But the paradigm has shifted. The emphasis when I first entered private practice 50 years ago, we were concerned about communicable diseases. And now the paradigm is shifting to non-communicable diseases and disabilities that are associated with aging. And so the language has also evolved to things like disability-free life expectancy and healthy life expectancy and active life expectancy being proposed by the World Health Organization. In most developed countries, though, we can expect that the last 8 to 11 years of our life are going to be accompanied by some disability or multi-disabilities. And we can look at that, Jackie. So in the demographics and aging of the world, the population 60 and over is going to really drive this train. They're socially and economically going to be demanding the care, and they're going to, and they already are, forcing us to restructure our thinking about the delivery of care. Since the last years of life are associated with increased disability and sickness, this is going to put enormous demands on our social and health services, and it's going to drive the costs of healthcare up even further than what they are currently. And these changes are going to limit the abilities of health and social and political infrastructure to deal with the magnitude of the problem. That's what we're trying to do. We're trying to anticipate a public health initiative that might anticipate the ways that we can deal with this. And networking and interdisciplinary, interprofessional linking, I think my personal view is it's going to be indispensable. We have to be smarter about how we're managing this care, and we have to go deeper in providing the care. Okay, Jackie. So this, just to give you some idea of what the disabilities are like. This is the 10 most common conditions suffered by nursing home residents. This was derived around the time that we were collecting the data for this study. But it is important to see a few points, and that is that 50% of the population is suffering 2 to 3 disabilities. 26% is suffering 4 to 10. So with just that population, we've got over 75% with 2 to 10 disabilities. These disabilities are mentioned within skilled care facilities. It's pretty much focused on cardiovascular or conditions, acute conditions that lead to disability. It doesn't surprise anybody, I don't think, in this age. And we'll talk about the demographics, but the age having a high prevalence of blood pressure And if you link blood pressure and just the heart disease aspect of this, you can see that it's over 90% of the patients have some type of systemic cardiovascular issue. And this is an important point that I'll bring out when we look at the vision data that we're going to look at. And that is that hypertension is not reported in the literature, not within the vision-related literature. It talks about the key age-related eye diseases, and yet this graph of comorbidities or chronic conditions doesn't mention anything about vision. So these are points that I'll bring out later in the presentation, but it is important for us to be aware of this and aware of the relationship between systemic disease and the ocular implications and vice versa. And I'll elaborate on that a little bit later. Okay, Jackie. So if we just look at the population that are 65 and older, and that's what we did for our study that was published this month. If we look at the scale, we can see that in 2010, there were about 1.4 million occupied beds in skilled care facilities. There's about 1.7 million beds available. So that's about 3% of the population at that time, which in the United States over 65 was about 40 million. By 2050, they're projecting that the population is going to increase to 88.5 million or 88.5 million. And that's going to further press the demand for skilled care need from 1 million or 1.4 to 6.2 million. So it goes from roughly 3 to 7% in long-term care occupancy. And we also know that now, or in the current period of this study, that we are looking at a nursing home residents surviving for about 30 months. So their age ranges from 1 to 5 years. But as I mentioned earlier, that vision and eye health, eye disease isn't counted as a chronic condition. So it's a very crucial point. And we can see also that the 65 plus population as a proportion to the total population is also increasing dramatically. It went from roughly 15% to over 20%. So this is a real significant problem. Okay, Jackie. So if we look at just vision impairment, we're a little bit more parochial in our approach here. We can see that, and I don't think we have to explain to this audience what vision impairment is, but it's anything poorer than 20/40, but not 20/40 or worse, but not greater than 2200. So this is a population that's vision impaired. And if we look at the way that this is distributed, you can see that the prevalence rates of low vision have a certain link with race. And that link shows that we have the white population at roughly, about 11%, and then the Hispanic around 15%, and then the Black around 17%. So the other important thing is that we know, and we'll be able to demonstrate in our data, that the preponderance of patients in skilled care facilities are white females, and the population of white females is 63% versus, population of females is 63% versus 37% males. Okay, Jackie. So then we look at blindness, which is defined as a best corrected acuity of 2200 or worse. And we can again see that now this is an age-matched cohort of ambulatory patients. There are no data that define the prevalence of institutionalized patients. And that's what we are really very delighted to report in this publication that's just come out this month. So, and again, we can see that for age-matched cohorts, the values where now for blindness, the white race gets the higher percentage at about 9%, and then the blacks followed by the Hispanics. So, but the prevalence in terms of blindness of females to males is almost exactly the same as it was for vision impairment. Okay, Jackie. So if we look at this in terms of the impact that we can have, and we can investigate what we're calling the vision exam. This is an important point because what we're singling out here is certainly the importance of correcting vision that is optically correctable. That's just icing on the cake for the point of this comprehensive exam. But what we're trying to do is to emphasize the importance of ruling out blinding eye diseases, like the ones we're going to describe, that have no signs or symptoms. So once the patient is admitted into a skilled care facility, they essentially drop off the radar screen. So if we expose them to a comprehensive exam and allow somebody that is comfortable looking inside the eye, we can open up a whole new frontier because we can see things because we're looking directly at the blood vessels when we look at the eye. So we can single out things like diabetes and hypertension, kidney disease, even brain tumors, in some cases, an earlier diagnosis than what symptoms would indicate. So there are opportunities for us to make a significant impact. The other really important thing is that these services, this comprehensive exam, can be done on a patient that cannot speak. And whether the patient is suffering dementia or the patient is intubated, there are opportunities to give them the same service and the same type of care. And I'll share with you some examples of that possibly later on when we talk about the individual patients. Okay, Jackie. So what's the impact of quality of life? Since the comorbidities are systemic, but have ocular implications, degraded vision is not the only factor that can influence mobility, but it's part of the whole picture. So we're getting a much more comprehensive assessment of sensory input on this story. The eye exams can be performed on site. We use miniature equipment. I carried 2 bags into the facility that had everything in them that allowed me to do a comprehensive exam as if I were in my office. And what we can do is single out color and contrast and other measures that are not currently assessed, but are easily translatable into the environmental changes. So this method works, and it works best with interdisciplinary communication, linking the professions all together and talking about it. So that's a summary. Jackie, I think the next slide. And this is just a basic overview of what's happened or what is happening in nursing homes in the United States. There are approximately 15,600 facilities, like I mentioned, 1.7 million licensed beds, about 1.3 million occupied. 2/3 of the nursing home residents, as I said, are female. The average age of a resident is 82.2 years. They're primarily Caucasians, making up about 75%. African Americans come in at about 21%, and the rest of the races are comprises about 2.5%. So these numbers are going to come up, and these numbers are based on ambulatory patient numbers, except obviously the reference to nursing homes. So I'd like to turn this over to John now and have him elaborate more on the practice. John?
Thank you. One of the things that we've talked a lot about is estimating the population of the non-institutionalized population. And the numbers that are presented on this slide are from a study that Rohit Varma did in 2016. And he estimated that there were about 12.4 million people in the US who had vision problems. Among those were 1 million who were blind, 3.2 million who had vision impairment, and then about 8.2 million who had uncorrected refractive error. So there's been a lot of attention in this country regarding vision impairment, and trying to estimate the population in multiple studies among the civilian population. What is distinctly missing among these studies is better understanding the prevalence of vision impairment and the characteristics of people with vision impairment in nursing homes, and that's the void that Bill's inquiry has really filled. And I just want to mention that this study that we're talking about today is in the current issue of the journal JAMDA. It's the publication of the Society for Post-Acute and Long-Term Care Medicine. So it is the current issue. And so all the data are presented in this issue as well. And then I would urge you to, if you go to that journal, is to read the editorial that Heather Whitson did on addressing vision impairment and hearing impairment in nursing home settings. So what's nice is that that this study has kind of precipitated the invitation to do the editorial, and is bringing some attention to this certainly under investigated topic. So let's go to the next slide. So we have pretty good, in fact, we are awash in data regarding vision and vision impairment among people in the general population, and we have fairly granular data that's available now. But within the nursing home, I think it's kind of, what gets asked about gets done. And in fact, vision does not get asked about in nursing homes. And there's a number of reasons for that, I think, that are pretty obvious. One is that vision impairment is not a particularly obvious disability. It may be that somebody has cognitive issues, and those become confused with vision impairment. And there's just not a systematic process to evaluate the vision among residents when they come into a nursing home. So there's big pieces of this equation that we do not know. Let's do the next slide. Okay, so so when we look at the population of people in nursing homes, there is very little available data. There are, in fact, a total of 11 studies that have been done between 1957 and 2007 that have attempted to examine vision impairment and eye diseases in a nursing home. This study is by far has the largest clinical sample, and it addresses both eye diseases and vision impairment. So I think so I'm going to be talking about first the available studies, and you get a sense of the dilemma that we're facing. Next slide, please. Okay, let's just go to the next slide. It's a very complex slide, and so don't worry about the detail in this. But what I want to do is summarize the other studies that have been conducted in this country. So there's 11 that are worth attending to. Just to summarize this work, the sample size ranges from 47 to 1,300 subjects in each of the studies. So some of the samples were very, very small. Two of the studies looked at the same population, and they had 1,300 people. In this study, we have 2,000 by contrast. And of the 6 of the 11 studies that have been published, identify eye diseases. And the prevalence of vision impairment, or prevalence of eye diseases, is all over the place. You know, people ask me, you know, how many people have vision impairment in the U.S., and I just say, well, you tell me the number you want, and I'll show you the study. There's no convergence in the findings from these studies. It is just remarkable, the variability of that. So it's not like the research has been moving toward consensus. It is just moving towards variability. So 6 of the 11 studies identified eye diseases. Cataract ranged from 32.5% to 83%. Glaucoma ranged from 5.3% to 41.4%. It's a pretty wide spread. Macular degeneration ranged from 4.6% to 70.7%. And diabetic retinopathy ranged from 1.7% to 3.1%. So there's very little, there's no convergence in this. Now, there's a number of reasons why, and I'll get to that in a second. The second is that 7 of these 11 studies identified vision impairment, and 5 of the 11 studies identified blindness among the population, and only 4 of the 11 studies identify both eye diseases and vision impairment. So one of the questions, and I'm interested in the kind of surveillance side of this. So why is this so hard? Well, think about, you know, if you're trying to gather data on the people in the nursing homes, there's multiple ways to do it. One is self-report. You can ask the person if they have eye diseases. You can ask them if they have a vision problem. But the respondents in this sample among people in nursing homes may not be the most reliable. So self-report is a very good method to use in the non-institutionalized population, not probably the best to use in a nursing home. You can also do chart review, but unless someone has examined the patient's eyes at some point and diagnosed an eye disease and report a vision acuity, there may be no information in the chart that reports eye diseases. So these studies have used chart report. I don't think any of these have used self-report. The third way that you can do it is to use staff report. And for all of us who know, who've had someone that we care about in a nursing home, the staff may not be reliable informants regarding the visual function of people in the nursing homes. In my case, they were lucky, they by and large didn't know my mother-in-law's name when we would call. So I don't know if they knew anything about vision impairment. But then the gold standard is to do what Bill did, is to do a comprehensive eye exam with each patient in the nursing home. And those are some of the findings that we're going to show. Okay, now I'll turn back over to Bill.
Thank you, John. And I think that what's important is, as John mentioned, is to have the data, to have consistent, reliable data. And it's because of that, we have not been able to have an impact on policy. We've tried. There were resolutions proposed by the American Public Health Association in 1992 and 97 that requested that mandated eye care be provided in skilled care facilities. The National Academies of Sciences in Engineering and Medicine report in 2016 again stressed the importance of it. And just recently, there's a Lancet committee on vision that reported out in 2021 that is mimicking the same call. But the real dislocate is that we can't quantify the impact that this type of care would have. And the priorities are obviously directed in good places like survival. So most vision problems are amenable to correction. They can be remediated sometime with, like I mentioned, simple spectacles, but we can have a significant impact, and I did for more than 20 years that I was doing this in skilled care facilities, by being there to treat these aggressive, progressive eye diseases. And that's what we're trying to impact. So Jackie, let's see the next one. So each vision factor that we're talking about has a potential for this, and we're just going to try to make these offers available and try to be as careful as we can about defining what this need is and the impact of what delivery of good care can have on this population. Next slide. So what we did then is that in this study, we collected basically 7 years worth of data from my patient records, which were 7,000 patients, or a little over 6,000. But anyway, it was reduced by the initial patient visit and also by patients in the facility that were 65 and older. And even with that selection criteria, we still have the largest sample size that had ever been collected at 2019 complete patient eye records. And this was from 20 nursing home facilities. So we can see that this has now the potential of being a source of good reference. Jackie? So I'm going to turn this back over to John now and let him describe more of the data.
Yeah, these are the characteristics of the population of people served in people that Bill identified in this very large sample, and I don't think it's anything particularly surprising about the distribution. The mean, you notice that Bill mentioned the mean age of people in nursing homes was 82, and we're right at that, 81 and 82 for people with vision impairment. As you would expect, there's more women reporting vision impairment and blindness than not. The distribution of people who are white, Black, and report other racial ethnic groups is also on par with those national studies. So suggests to me that this is pretty much a representative sample. But then let's look at the findings on the next page, which are really kind of surprising. So in my view, this is, besides the total population, this is the most surprising finding. So the middle column shows the prevalence of cataract among people who report vision impairment, that is 2040 to 2200. And so 65% of people report cataract, 23.4% of people with macular degeneration have vision impairment, 2040 to 2200. 26% report glaucoma, and 7.1% report diabetic retinopathy. But here's to me, an incredible finding. Of people who report normal vision, that is 2020 to 2040. 52% have cataract, 21% report macular degeneration, 20.5% report glaucoma, and 6.7% report diabetic retinopathy, or diagnose, I should say. So while about 65% of the residents of nursing homes in Delaware report vision impairment or blindness, people who are reporting normal vision also have high prevalence of eye diseases. So what it suggests to me is that even those reporting normal vision are at risk to develop vision impairment. So vision problems are almost universal within a nursing home setting. And I think these data are really striking. The next slide, please. Okay, now this shows the percent distribution. Oh no, I want to go. I want to mention just one other thing regarding the last slide. You don't have to go back, but Bill's finding. Oh, there we are. Bill's finding shows that about 65% of people in nursing homes report cataract. Remember, I showed those other studies, and the other studies show a range of 32% to 83%. So Bill is in that. Notice this huge range of disability of cataract, but these are diagnosed cataract. In the other studies for macular degeneration, in this study we show 23% of people who are reporting vision impairment having macular degeneration, 38% of people with who are report vision impairment and blindness. Remember this, the other studies show a range of 4 to 70%. So I think we're kind of moving toward a gold standard in this study. For glaucoma, the report is 26% among people with vision impairment and 40% blind. The other studies show 5% to 41%. And then diabetic retinopathy shows a 1.7% to 3.1%, but Bill's study shows that 7.1% of people with diabetic retinopathy report vision impairment. So these are striking findings, and what I would suggest are probably again the gold standard for this. Then we go on to the next slide, and this just shows again the percent. These numbers are just astronomical to me. So among people 65 to 74, 61% of the residents in the Delaware nursing homes report vision impairment and blindness. Of those, that's 61%, about 11% are blind, 2,200 or worse. And what's interesting is it's kind of stable among people 75 to 84 and 85 to 94. But for the old, those 95 to 80 to 104 in this sample, 80% have have vision impairment or blindness, and 25% have visual acuity of 2,200 or worse. So these are, I think, again, kind of striking findings. Bill?
So what we did was we put together the manuscript that John described, and there were some really very positive immediate feedback from this, because we in the process of going through the review process, the reviewers' comments were actually complimenting and recommending that we explore the outcomes more, and it allowed us to elaborate more on those issues in the paper. The other thing that John mentioned is the fact that the journal opted to do an editorial to emphasize the importance of sensory loss, vision and hearing. So all of that's complementary to, in a very positive reinforcement for what we've been doing. Next slide, Jackie. So we have an epiphany. So we've learned from working in this special environment that we can make a difference, and it's not limited to vision improvement. And anybody that's worked in a skilled care facility and worked with patients in skilled care facility knows that if you interact with that patient, whether it's vision or physical therapy or whatever, you're going to learn and be able to observe things that you can share about that patient's progress. So you might have impact on cognitive, you might have impact on safety or activities of daily living that go beyond the obvious sensory contribution to these factors. So this is a very exciting side benefit. Next slide. So what is the public health impact? Like I mentioned, we're trying to emphasize, as public health does, prevention and the capacity to maybe avoid institutional care. But we're working with a system right now that with the data that we have had available is fragmented. So we've still got a ways to go. Go ahead, Jackie. So I just very, very briefly, I know that we want to try and save time for questions and answers, and we're rapidly running out. I just wanted to share with you some of the dramatic examples that I said that I would earlier on of patients that I actually saw and took some photographs of the insides of their eyes so that I could demonstrate what we're doing. But before I go to the next slide, I did want to back up and pick up some important issues about simply refractive problems or examining patients who cannot speak. And the dramatic examples I had were a patient that was basically left to deteriorate, that had dementia, had cognitive loss, and just basically was bent over his wheelchair all day in the sunroom. And I asked if I could examine him, and they thought that I was crazy, but they let me do it. And it turned out that the person had a significant refractive error. So I went ahead and prescribed glasses for him. And when I put the glasses on him, he straightened up in his wheelchair and he started looking and interacting and paying attention to the environment. So those kinds of things are not tangible things that you can report. They're anecdotal. And the same happened with a wonderful lady who was in her late 60s that was intubated and bedridden. And she was a voracious reader, and she quit reading and was very sullen and very depressed. And then I did an exam on her, and I found out that she simply just needed some help to see close up again. And when I put the glasses on her and put a book in front of her, she started to cry. She couldn't talk because she was intubated, but I got the message that this makes a difference. And that's why we're doing this. It really is to have an impact on this population that is so horribly underserved, not out of malice, but just simply out of priorities. And we want to stress this as a priority. So let me show you very quickly what some of these conditions look like inside the eye. Next slide. It's funny, what we're looking at now is basically what we call end-stage disease. But it's important for you to understand that when I did these assessments, there was no prior care. There was nobody coming. There was nobody on the horizon. And so what I saw was what the impact of no care would have and what that reflected. So here's some examples. So this, and it's really, I only did one patient example on this because I just wanted to show you the complexity of the patients. This was a 57-year-old African-American male. he had cataracts, he had high blood pressure, he had diabetes, he had coronary artery disease, he was in end-stage kidney disease, so he's on a dialysis. He had had a double amputation above the knee on the right and below the knee on the left. He had no history of drugs or alcohol, and he had some significant cognitive problems. But if we look inside of his eye, the next slide, we can see that some of this is related to the complexity of his health. And if you look at the back part of the eye, the first thing you see is that little white circle. That's the optic nerve. And then the little tiny blood vessels that come off of that tell us what the status of those vessels are in good health and in very bad health. And so this is the result, the end result of diabetic progression. It's called proliferative diabetic retinopathy, where there is bleeding and resorption in the eyeball that results in permanent scarring inside the eye. The white dots that you see there are attempts with laser surgery to close down some of the bleeding and to stop some of the bleeding. So there was clinically significant macular edema in this patient. He had proliferative diabetic retinopathy, and he had that connective tissue scaffolding. This was in just one eye. So it really becomes important for us to see what vision is still available, and then what about the vision in the other eye? So these are the kinds of things that you deal with in this population. Next slide. This is just another patient to show you, again, the white thing that looks kind of like branch-like is a blood vessel, and that's a blood vessel that has shut down. So the patient had a stroke inside of his eye. The caliber of the blood vessels is very, very narrow, very, very attenuated. That's an indication of cardiovascular disease, hypertension. And then those black dots are treatment for diabetic retinopathy. That's what they do. They burn spots in the back of the eye, hundreds, thousands of spots in the back of the eye to decrease the metabolic demand and to not eliminate, but slow down the progression of new blood vessel growth, which is horrible, aberrant blood vessels. So that's a glaucomatous nerve in the back of his eye. So he has glaucoma, he's had a stroke, and he has high blood pressure and diabetic retinopathy, all wrapped in one package. So that's those are just some examples of what we can see if we look. This patient is asymptomatic. They do not have a sense other than ultimately going blind. And what we're trying to do is prevent that and trying to have the vision outlive the patient. That's our goal. So the next slide. So how we handle these comorbidities and vision loss and have an impact on quality of life is really very rewarding. And it's something that I hope that I can convince my professional colleagues to join up with. This is hard work. This is really, really hard work. It's tough diagnostics. I've never had a problem with a patient. I've never had a problem with a patient. I had many, many difficult patients, but they were never so problematic that I couldn't handle it. So the impact that we have is mortality rate, increased falls, decreased mental health, compromising quality of life. All these factors we can have an influence just by taking the time to look. Next slide. So in conclusion then, vision and eye health, I hope that you can see, is an important central issue and care for nursing home residents. Our study showed clearly that we have, 63.8% of these residents are vision impaired or blind. Going blind possibly unnecessarily, or maybe blind simply because they don't have a spectacle correction. The high proportion of vision impairment in age-related eye disease suggests that the eye health should be well integrated into this patient's health care. And the lack of consistent measures of visual function is what John mentioned with the importance of surveillance. We have the capability of defining this. We can scale these data and help the clinicians record it in a way that is very, very amenable to them providing a solid database for surveillance of people that are institutionalized. So a systematic method to collect vision data could be established, and foundational evidence to improve eye health. And all of these factors, environmental included, are possible. The next slide, Jackie. So thank you very much.
This is Lee Nasahi. I don't have a question. I want to just thank you both for this presentation and just want to say, wow, what are we doing about this? Oh my goodness. Thank you.
Thank you.
Thank you.
Hi, this is Sam. Wanted to thank you also for the presentation, very informative. I work for a company called Humanware, and they make products for visually impaired, low vision, and blind. Have you seen many patients in these residences that use special assistive technology to magnify print or to read books in a digital format, fully accessible for visually impaired?
Very limited, Sam. And again, that opens a very important point, and that is that if we can get healthcare or eye care providers in there that are skilled in rehabilitation and skilled in low vision, it can be part of the package. It doesn't create a problem. But to answer your question succinctly, I saw a few readers. I saw no magnifiers in 7 years. So
that's very sad, you know, because these devices are simple. They got 2 buttons on them: zoom in, zoom out, change the contrast, and you know they can change lives. And obviously they're available, but they're not under the healthcare program. So I understand that complicates things a bit. So yeah, we'll keep visiting the homes and showing them the products, and hopefully that'll help in certain conditions where your eyes cannot be corrected with glasses. Thank you for that.
Thank you.
This is Neva Fairchild with American Foundation for the Blind. I'm wondering if you have any kind of a sense of the people that you studied and whether they went into the nursing home or skilled nursing facility because of their vision. If there's any way we could know that.
You know, that's a very, very important question, Nina, and one that John and I discussed when we were writing the paper, because it would be wonderful if we could get some clue as to the treatment effect and also an impact. It was not possible for me to do that. Basically because it was structured as a clinical delivery of care. But I think that if we could just get some attention and some support, it's all about trying to get funding. You know, really, the source of this is possible. We could go in and based on what we know now, we can structure the exam form. We could structure the questions. Ideally, we could get a very quantifiable assessment of cognitive ability, something that would be tangible and amenable to analysis. So yeah, I think that's a top priority. Right now, we're working on another data set. A colleague of mine provided me with, has a large practice in North Carolina, and has provided me with 40,000 patient records now. And we've culled it down to 10,000 patient visits. But again, it's clinical, and it has its limitations, but it's going to really, I think, reinforce how important this question is.
Yeah, let me just add to that. I appreciate the question. We have no system of care, and if if we had a robust, well-integrated system of eye care and vision rehabilitation. I think there's the potential to avoid institutional care and to provide vision care and vision rehabilitation for those people who are in nursing homes if you cannot prevent institutional care. But as it is, and it's pretty obvious, I mean, people end up in a nursing home because by and large, I suspect, because of some kind of precipitating event that may or may not be related to vision impairment. And therefore, because we have a fragmented care system, but if we could kind of reimagine what that might look like, so that we have good eye care integrated with vision rehabilitation throughout the aging process, then there's potential to avoid institutional care and improve the quality, the quality of life and function for people who are in nursing homes.
This is Larry Johnson. I would like you to address the composition of the nursing home residents. It was rather surprising to me to learn that predominantly these are white women. My understanding has been that such things as diabetic retinopathy are much more prevalent among Hispanics or African American, and because of also poor health care, that other conditions also contribute. So why is it, do you suppose, that there is not a greater number of residents from those ethnic and racial categories?
Well, I think the simple answer is that these data were collected in Delaware. At the time that I started the work, there were 48 skilled care facilities in the state. 24 of them agreed to allow me to provide the eye care. And I think that may have been a partial reason that we had the data broken out. But I don't think we're going to find that it's a huge aberration. There are cultural differences. There are other social reasons that we don't see it. But if you look at, as I mentioned in the NEI data, the prevalence, as you mentioned, prevalence of diabetic or blindness related to diabetic retinopathy is higher in African American populations. So we just didn't have that in our sample. That's all. And I'm very curious to see what's going to happen with our North Carolina data, to see if we could. And that's another reason I'm so happy that one of my colleagues stepped up to allow us to analyze it. John, did you have anything to add to that?
Yeah, I suspect that one factor is a cultural factor. I think Hispanic families tend to provide care across multi-generational families. And I'm speculating, but I suspect that is one of the factors. When we look at the non-institutionalized population, the patterns that you mentioned, Bill, certainly are consistent.
Well, fantastic. We really appreciate your time. I think we're right on the end of the hour here. I want to be cognizant of people's time here. We did have a last really good comment from Kira here. I just wanted to read before closing out, and that was, Bill and John, thank you so much for the opportunity on this. I think there are some opportunities to improve vision within Medicare. The ITEM, ITEM Coalition is working on coverage for low vision devices not currently paid for by Medicare. Also, there is a new enhanced reimbursement for primary care providers for a full cognitive assessment. Part of that assessment identifies a possible vision problem, but there is no coverage for an eye exam under Medicare for a diagnosis of vision problems. That benefit should be added.
Yes.
And I think all of us can agree with that.
Yeah, that's wonderful news. Now, Medicare will, most of these patients are spent out of their Medicare within the first 100 days, but there is the possibility for reimbursement through Medicaid with this. The only thing that they don't cover is the optical portion of the exam, but they will cover an exam if it has a medical diagnosis. And it's impossible to see one of these patients without documenting a medical diagnosis. So that's the good side, but it's wonderful to hear that this is getting some visibility. And if the resources are there, if it comes to it, it will be much easier for us to recruit professionals that need the care. Now, one caveat I would like to stress is that we talk about screening and doing screening exams. My personal opinion is that this can't be done with a screening exam. I think we tried to do that with glaucoma many years ago and set up glaucoma testing devices at Walmart and places around town that had very, very poor results. So it does require looking. And just one final point, and John was very kind to mention the manuscript and the fact that it's published now. And I would encourage all of you to try to look at it and also take a look at the editorial he mentioned. But I also want to thank John because he's the co-author on this paper and he contributed a significant amount to bringing it to the level of complexity and the level of attention that I think it really deserves. So thank you, John.